Well, thank you to yourself and the Cardio Care Today audience for speaking to me about our paper today. Really, it was inspired by the fact that we're all aware of the massive population global public health crisis of aging. The WHO estimates that in the next 5 years, 1.5 billion people will be over the age of 60. That's 1 in 6 people. And it's not just a problem for rich and high-income countries. By 2050, it's expected that 80% of older people will live in low and middle-income countries. So it really is a global health problem. But our inspiration really came from our local population in Norfolk. So Norfolk's in the UK. It's a popular retirement destination. It's close to the coast and a big national park. And what we find is that people really want to move there when they retire. So we've got a very elderly population. In fact, some bits of Norfolk really are the oldest in the country of the UK. And so we're really seeing that population crisis in our hospital when we treat patients. So when we talk to patients, everyone understands that aging is a natural part of life. They all understand that it's going to happen. And their real priority is, can I age in a healthy way? They want to maintain their independence. They want to have a good quality of life, and they want symptoms that are manageable as they age. And so this is really what we set out to do. We wanted to understand the biology of aging in more detail. We already know that there are cellular and molecular processes that happen with aging and that lead to trouble. And we wanted to see whether that also correlated with heart function and size changes using cardiac MRI. So our study was motivated by our own population, the global population, and the need to understand the biology of aging as it occurs. What I would say about cardiac MRI is it really is the gold standard in assessing the heart volumes, in assessing the heart function, in assessing tissue characterization, and increasingly in assessing hemodynamic physiology of the heart. So it's a great test for looking at all those different things and getting a sort of multi-parametric view of heart function. And the other thing that's great about cardiac MRI is it doesn't use any ionizing radiation, so it's safe to apply. And that was a particular consideration for us in our population because we're using healthy volunteers and also patients who were younger. So we recruited a cohort of patients across several different countries, 191 in total who were healthy, who had no known cardiovascular disease or risk factors, and across several different age groups. The centres involved were 3 from the UK, so Norwich, Sheffield, Leeds, but also a centre in Singapore and a centre in Spain. And all these patients underwent a cardiac MRI. And then what we did was we used an AI-supported algorithm to rapidly calculate the volumes and functions of all 4 chambers in the heart in these patients. So they were all consistently analysed across the different centres. And then we looked at how age of the participant affected all those different sizes and volumes and functions that we'd measured. And in general, what we tended to find was that the atria overall increased in size and reduced in function over the course of the aging process. The right ventricle tended to decrease in size, but increase in function when you measured the ejection fraction with age. The left ventricle did tend to reduce in size. The function in terms of the ejection fraction stayed fairly static. There was a signal as you age that it might then start to increase in function in terms of ejection fraction measurements. So we looked across all those different volumes, those different functions, and we were trying to ascertain which one changed most strongly with age, but which one was also most linearly predictive of age as well. So both sort of simplicity and strength of association. And the 2 factors that we came out with was the size of the left atrium, so the left atrial end-systolic volume, and also the function of the left atrium, so the left atrial ejection fraction. And we used those 2 parameters in a regression equation to estimate the patient's heart age. And it's not really surprising to us that the left atrium comes out as this excellent predictor, because it's on the left side of the heart, so it's exposed to the systemic circulation, so it's exposed to all the hypertension and vascular risk factors that we know about. But it's also a thin-walled structure, so it's much more likely to dilate when the pressures inside the heart increase. So a lot of our work in the past has been about using volumetrics to estimate the pressure inside the heart. And I suspect what we're seeing is an age-related increase in pressure being reflected in the left atrial volume and therefore function. We derived the CMR heart age, and then we went on and applied it in a different cohort of patients who were aging. Obviously, there was a spectrum of age, but also had at least one risk factor for cardiovascular disease as they aged. So the risk factors that we examined were hypertension, obesity, diabetes, and atrial fibrillation. And we picked those risk factors because they're common, and we also picked them because they're modifiable as well. So they're things that you can do about and hopefully improve outcomes. So the total unhealthy cohort was 366 patients in size. And what we found overall was an average increase in the heart age of 4.6 years over and above what the patient's actual true chronological age was. That did vary depending on which condition you were looking at and which risk factor. So hypertension overall is up to a decade increase in the heart age across many age groups. Diabetes led to several decades worth of increased age, particularly on lower age groups. Atrial fibrillation, again, a consistent increase in age across all age groups. Obesity was a little bit more complicated. It did depend on the degree of obesity. It was not significant, although visually it was slightly higher on the lower BMIs, but as you get up to BMIs of about 35 or 40, then you're seeing several decades of increased functional age of your heart because of that risk factor. So I think what we're measuring there is the downstream effects of these risk factors and all the cellular processes that are associated with them. So left ventricular hypertrophy, inflammation, oxidative stress, telomere shortening, all the kind of mechanistic factors that we associate with aging are being picked up as subtle volumetric and cardiac dysfunction that you can see with cardiac MRI. So I think I'd say that the purpose of this study was to introduce the concept of the heart age, to derive the equation, and to show its utility in some common risk factors. We didn't directly look at any hard outcomes associated with the heart age. So we didn't go on and follow up for death, heart attack, stroke, heart failure, all those things that would be useful to look at when you're thinking about risk factors. That all would require further study, which we hope to conduct prospectively, looking at outcomes. What I would say is that we did specifically choose the risk factors of interest because we know that they associate with outcomes. So we think there's a good chance that heart age will associate with patient outcomes in the future. And we also chose them because we know that they're modifiable. So there's already a good evidence basis that we should treat blood pressure, that we should treat diabetes. And so it stands to reason that heart age might support those treatments. Sure. So I think early intervention is a definite implication. I think the main use for the heart age will be in patient communication. It's a patient communication tool. Everybody understands what aging is. Everybody goes through it. Everybody sees people age. It's a universal experience. A patient knows what a 20-year-old looks like compared to what an 8-year-old looks like. And so if they have a cardiac MRI scan and you're in clinic and you're discussing lifestyle factors, you're discussing starting medication for treating blood pressure, and the patient's 50, you could potentially tell them that actually, although you're 50, your heart age is actually performing at the same as a 70-year-old. And taking the communication from there, asking them how they feel about it and what factors they'd like to think about to try and improve their heart age and their outcomes. So I think that's the big immediate application of it. I also think it could help clinicians because it's a single simple number that boils down lots of different processes going on. So it could be quite difficult to integrate all the different heart volumes. We've really picked out the left atrium is a very good one to look at in the course of this study. And giving a single number where someone who's reporting the MRI scans could say, actually, you know, there is a big discrepancy between this patient's heart age and their chronological age. Perhaps they need screening for these modifiable risk factors and putting that on the report to trigger further downstream testing. I also think it's got the potential to personalize treatment strategies more. So you might be quite aggressive in your risk factor modification for a 20-year-old who's got a heart age of a 60-year-old, and you might pursue different treatment avenues compared to, say, an 80-year-old who's got a 84-year-old heart. The difference is much lower, and probably you wouldn't want to accept potential risks or adverse outcomes for that patient. So I think those are the three kind of immediate areas where it might benefit. Your question also related to routine screening. I think that's a much more difficult question. For routine screening, you would want a validated prospective study, particularly with outcomes showing that you could improve outcomes by using the test. And then also you need to have an acceptable rate of false positives, false negatives going forward, and the test has to be available and acceptable to everyone. And that's a much bigger study involving health economics as well. So I don't think it's immediately going to be applicable for routine screening. I think it might be applicable for pragmatic screening. So you've got a patient who's having a cardiac MRI, you can report the heart age and then use it when you follow them up in clinic. So I think that the test will enter mainstream practice, but it does require further validation. So those prospective studies that we talked about, you would want, if you are communicating to patients, to be able to say your heart age is 70 now, but actually if you do this, perhaps your heart age will reduce to that of a 60-year-old. So I think that's the kind of information we need going forward from this study. And in terms of also increasing its applicability, integrating it more into the general work stream, making it simple to calculate for doctors. I think that the test has a good kind of potential for that because everything in it is routinely measured on every CMR that's done in the world. They're easy to measure volumes, and they're also very easy to automate in terms of AI. So what I would sort of see is more and more integration of the CMR heart age and any subsequent refinements to it being kind of automatically calculated by the scanner and therefore given to clinicians as an almost sort of free piece of information that they can then go on to use with patients. I do think there's challenges to its implementation. So it needs to be accepted into guidelines, which requires that evidence basis. CMR is obviously a specialist test. It's not available everywhere. So there's sort of an access issue and a cost issue. I think that will get better as more and more centers get CMR. And I think the fact that it's operator independent and amenable to AI actually will help that process as well. I think the final thing to say is it's also going to require a period of clinician experience and familiarization and also education about how you communicate the information to patients and how you use it as a motivational strategy to improve health outcomes.